Okay, 2 routes of administration, 2 big broad categories, okay? I've mentioned this earlier, but enteral, I know the verbiage, the language is wrong, but I think of that inside, taking it into the mouth. Enteral, it has to go through the digestive system. Now, drugs that are PO, per mouth, are enteral. Drugs that go under the tongue, sublingual, are not enteral. We're going to give a patient, under certain conditions, a nitroglycerin tablet, and it's going to dissolve under the tongue. That is not enteral. That did not go through the digestive tract, did it? It just went to the oral mucosa and was absorbed that way. When we give something enteral, it has to go through the GI tract. Glucose would be an example. Does that make sense? Because it's got to go down to the gut. Aspirin is an example. When we give a patient some aspirin and say, chew these and swallow them. Another thing you can say about enteral is swallow. If you swallow it, it's enteral. Yes, Billy?
So for under the tongue, they keep it there until it dissolves, right?
Yeah, and they're going to swallow eventually, but the route of administration was right there. Kind of like there's some B vitamins you can give under the tongue. You could probably go to Walmart and get you some B complex and say put it under the tongue. Some of these people taking the GLP-1 agonist, the semaglutide. There's injectable under the skin, and there's also a route that you can do under the tongue. I didn't know that until recently. Parenteral, all the other ways. IV, IM injections, topical, anything other than the gut is parenteral. Good enough? And I'll confirm in Canvas that these PowerPoints are posted. So if I go too quick and you don't get all this written down, just make yourself a note. It will be posted. And this is a PowerPoint from your publisher in the textbook, so it should follow hand in hand with that, Amber. So up the butt, per rectum. EMTs don't have a drug in their toolbox that we would give per rectal. Paramedics do sometimes have drugs we will give per rectal. We will give babies a Tylenol suppository. We may give an adult an antiemetic medication. It'd be kind of senseless to take a medication to keep you from throwing up if you're throwing up. So we give it per rectal, and it could be absorbed into the bloodstream. Do you have to? If it's in your protocol and you didn't do it, it would be an act of omission. What is the punishment? It won't bother you too much on a kid. It really won't bother you too much on a kid.
I don't want a grown man.
I think it would.
But it has bothered me on dying cancer patients who needed the antiemetic and the anti-anxiety or anxiolytic per rectal, because it's just an honor thing, you know. It's like you got to. They kind of know what you're doing oftentimes, and I had to do it with my grandfather, and luckily a friend of mine was there who was also a paramedic. We were down there messing around in my shop, and they said, "Hey, your grandpa needs his suppository. Can y'all come help?" And he did it for me, so I didn't have to do it to my own grandfather. So yeah, you're going to encounter it. I mean, we take temperatures in the butt sometimes, so it's okay, Hunter. It's all part of it, all right? You've probably pregnancy checked a cow before, I'm just guessing, but a cow's a lot different, is it? Okay. We'll work on that, Hunter, okay? IV in the vein, IO into the bone. Now you won't be able to do that per rectal, but you'll be able to take the cordless drill out and drill a needle into somebody's bone. Okay, yeah. All right. A little baby's bone? Some of those don't have the cordless drill. Sometimes they just have the needle you hold in your hand. You twist it and push and go, and you'll feel it pop. You can do that in a little 3-month-old?
I probably wouldn't throw it.
But you can't do something. Okay. Each to their own, right? Sub-Q, under the skin. Your TB test was not sub-Q. Well, they may have made it sub-Q, but it's meant to be intradermal. It's supposed to be actually in the skin layer. I find a lot of people have trouble doing a intradermal injection and ends up sub-Q, which invalidates the test.
This is completely random, but what are they trying to find with the TB test?
No, it is not completely random, and it is a great question, and you should always ask questions about that. If you have tuberculosis in your body or have had it in your body, you have built antibodies against that. Okay? Right? Just like if you've had smallpox or gotten a vaccination, you have antibodies toward it. So you have antibodies toward tuberculosis. They're going to put an allergen under the skin, and if that skin reacts, that tells them that you've been exposed to or have had tuberculosis, that you've built antibodies. If you got a positive skin test, they're going to go make you get a chest x-ray. And guess what? You can still go to clinical. It doesn't keep you out of clinical.
Good to know that now. Probably would have cried if it came out positive before.
So what does it do if I'm positive? What does it look like?
It's just a rash.
Comes irritating blisters.
It looks like whenever I showed up 2 days later for them to check it, I was there for 30 seconds.
Yeah. We used to do it here. I'd give you, and I'd check it myself. And they're like, no, you're not a nurse. But it's a nursing student, usually, that's giving it in the health department. It's a great way to get practice with injections, and that's my point. A lot of times they give it sub-Q instead of intradermal, and it's not valid then anyway. The whole thing is just a... We used to make you have a Hep A vaccination, but we don't make you have the Hep A vaccination. You work at Whataburger Sherman, you had to have a Hep A vaccination, but we don't make you have to have a Hep A anymore. And the only reason we made you do a Hep A years ago is because Grayson County was a hotbed for Hep A. Most of you probably have had Hep A by eating out. It's transmitted the fecal-oral route, if you want to know. How do you get Hep A? You eat poop. You ingest poop. Hunter's like, and to my point. I had a student last year ask me, would it be better if we didn't know this stuff? I said, you'd get along in society a lot better. But I just walk out with an attitude now. I was like, you got Hep A and you're cooking my food. I saw a cafeteria worker one day. I won't tell you where the cafeteria is. Had the gloves on and was picking lettuce out of his teeth as he was serving the enchiladas. Sub-Q's beneath the skin, intramuscular into the muscle. IM injections are into the muscle. So can you guys rank these 1 to 4? Which is the fastest route of absorption? IV first, IO, IM, and then sub-Q. You're going to give an EpiPen. We're going to teach you probably tomorrow how to use an EpiPen. It's real hard. Got to count to 10 to make sure it's all in there. It's in there, bud. Okay. It was in there within about a half a second of you sticking it in the leg, but we got to be sure because that bitch was $700. We don't want to waste it. Right? The more life-saving, the more cost. And you can't convince mama that she can go to the vet clinic and buy a 30-dose vial for $6, and I can teach her in 10 minutes on how to administer it. But you can't teach little Johnny how to administer it. I always find that insulting to me that I've got to teach you how to use an EpiPen when I teach 6-year-old Johnny how to use it. Stick it in. How do you administer one? You stick it in. Where do you stick it? Right here, Johnny, right here. Stick it in your leg. You can stick it in the arm. You can stick it in the deltoid if you wanted to. You can stick it in the gluteus maximus. You can stick it in the vastus lateralis. It's IM. It's going to go to work immediately. Now, a paramedic, when someone's in cardiac arrest, can give 3 times the amount of epinephrine that you would get in an EpiPen in the IV. What's the difference in you giving it to Johnny in the muscle and the paramedic giving it to a guy in cardiac arrest in the IV? One's dead, but one's real close. Little Johnny's real close. I can give epinephrine to someone suffering from status asthmaticus sub-Q. Why would I give epinephrine sub-Q in an asthma patient instead of IV? Gets in there slower. It's going to have a longer last. It's going to last longer. Longer lasting effect. And it won't be that big rush of, just full onslaught of epi. Where do I give that to? I give it to somebody who's not breathing and doesn't have a heartbeat. I give it basically to the dead. You with me? Okay. Inhalation is into the lungs. We use that with our meter dose inhalers. Did y'all do meter dose inhalers last Thursday? Mm-mm. You did nebulizers though.
Yes.
Yeah, nebulized medication, same way. Sublingual, under the tongue. You guys will play with that with nitroglycerin. And Hunter, I hate to be this way, but there are some people that I'm just as grossed out with their mouth when they open it. Oral health can be very ugly in certain patient populations. An oral health exam can tell you a lot about the patient's overall health. If they've got missing or decayed teeth to the point where it's just rotten in there, they're also malnourished. If I see white spots on their tongue, they have thrush. They have a... So we're going to give nitroglycerin sublingual. So we're going to get this little tablet out, or we're going to take a spray. We'll see those tomorrow. We'll have the patient raise their tongue. We will direct them, do not chew this, do not swallow this, let it dissolve. And the nitroglycerin should help relieve their chest pain, because we give it in a chest pain patient. We have some indications and contraindications. But the nitroglycerin should also burn under the tongue. They should feel discomfort. It should give them a headache. It should burn under the tongue. Nitroglycerin is not a stable compound, and we know that because it's an ingredient in dynamite. So it's not a stable compound. So
Why is it that has to be under the tongue?
why does it have to be under the
I
tongue?
know it dissolves, but is it just...
It doesn't have to be only under the tongue. We can give it IV as well.
It means like in your mouth, like where you
Like,
just
what happens if you
dissolve
swallow
in
it?
Why can't
What
you-
happens if you swallow it?
No, why can't you just keep it in your mouth? Why does it have to be under the tongue? Yeah. Why can't you just put it like in your
Oh, it's got to be against the oral mucosa. That's where it's the thinnest back there, under your tongue. If you look under your tongue, you can see the blood vessels.
No.
It's very vascular under there. People who have tongue piercings, when they take them out, they'll heal within hours. You'll find a subset of the population who cuts the frenulum under their tongue so their tongue will stick out further. And when they do that, it's painful. It's extremely painful because it's rich in nerves too. It's your taste sense, but it heals very, very quickly. But it also bleeds like crazy. Don't ask me why they cut that, because I could tell you. But it would not be appropriate for the classroom environment. Gus is like, Now I'm curious.
How'd they do it?
I'm not telling you.
Another experience.
Some rock star did that. Who was it? Gene Simmons?
Those kids.
Transdermal through the skin. That's where your TB test should have been performed. And then intranasal into the nostril via a mucosal atomizer device. In our world, we abbreviate that MAD. So you're going to hear that in the lingo, the jargon of the business. And if I tell you, Drew, that they're getting it through a MAD device, metered mucosal atomized device. Nobody calls it that. They just call it a MAD device. That Narcan that you stick up somebody's nose and press it to get the Narcan in, that's through a MAD device. Make sense? Intranasal. Sugar? No. Yes?
Do they have to be like breathing to use the Narcan in the nose?
No. No. They do not. Do they have to be breathing for inhalation? By some means, whether mechanical or on their own. Either I'm breathing for them or they're breathing on their own, right? Good question. They do not have to be breathing for intranasal. You're just trying to hit the mucous membranes back there. Highly vascular, right? Most nosebleeds, we have a name for nosebleeds. You want to know what it is? That's a runny nose. Congratulations, Billy. You're close. You're close. Rhinorrhea. Epistaxis. 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 That's a nosebleed.
I got that confused so many times. First time I took the course, I thought it was some word that was like having to deal with the major part of the body.
You've taken this course before?
Yeah.
Which one you like better?
Well, not this course. Sorry.
No, which one of those do you like better?
This one.
Okay, thank you. Good answer. Good answer. Much better?
Wow.
Oh, hell yeah, I'm good today. A lot
There's
better.
a fat gap between there and this one.
Oh, what kind of gap?
Fat gap.
A fat gap? Oh, it's all relative, right? It's all relative. Epistaxis is nosebleed. What's the number one cause of epistaxis? I'm doing this for a reason, y'all.
Yeah, Grayson.
Digital trauma.
Picking your nose.
In this room, when I speak and I say the word digital, I'm talking about your digits. Not computer software, imaging, cameras, the digital world. I'm talking about the fingers. There is a technique we use in paramedicine where we digitally intubate someone. I walk my fingers down their throat until I feel their epiglottis, and I lift their epiglottis up. And with my other hand, I stick the tube down in there. Hunter's like, no, we ain't. We ain't sticking anything in anybody that belongs to me, right? Hunter's like, my fingers aren't going there. That's called digital intubation. And I've had I started having people miss that question a lot in the last 5 or 6 years. And I'm like, why are you missing that question? And they're like, you're talking about through the use of cameras, right? I'm like, no, I'm about the use of your digits. Digital trauma. Okay, we got to understand the lingo, guys. We've already done this. Thank you to the group that volunteered to help on this. So I want to get to, everybody knows the difference between a capsule and a tablet, suspension and a solution. Don't worry about that too much. If it's suspended, it will also settle, so you got to shake it. No big deal there. This is a powder. It's just in an aerosolized form. No big deal there. Topical, we don't do much topical, but you can see some examples: calamine lotion, neosporin. There's also nitroglycerin topical. So you can be admitted to the hospital and they'll give you some nitro paste. We used to joke around with that. We'd put it on door handles of the ambulance and stuff, and people would get nitro in their skin and it would lower their blood pressure and they'd get dizzy and pass out. Real smart if the guy was the driver.
So would, I guess, grandma's fentanyl patch be considered
Topical, yes. No. Sorry. Transdermal. The topical, if you'll look at all these, they're working right there at the skin. The transdermal's going through it to get to the bloodstream. These aren't necessarily going to work by going into the bloodstream. They're working right at the surface of the skin. Good question. That second bullet point answered it. Yeah, transdermal. I don't even think we had transdermal on the list, did we? But that's super slow, isn't it? That's super slow. It's a lot different than smoking fentanyl. Nope, there it is. Transcutaneous or transdermal. Sorry. There's your answer, Sterrett. If you touch the medication with your skin, you'll absorb it just like the patient. Hence, if I find someone's got nitroglycerin paste on their chest, and some people actually take it home and they say, put a 1-inch line across your chest 3 times a day, or put a 1-inch line anytime you feel discomfort. Do y'all see it in the ER? They'll put nitro on the chest. The pill or the IV. Like I said, we used to get a hold of it and prank each other. Not smart at all. Not recommended. But if I gave you a big old swap of nitro paste on your chest, you probably pass out from low blood pressure. Even you as a healthy individual, because it's a vasodilator. If just to make them dizzy. We're actually doing it for that headache, because you get that flush headache there for a minute. None of this is recommended, by the way. What did I tell you the other day? The number one bullying profession is in hospital or medical workers. I'm telling you this for a reason, because when I do CPR on someone and I put a defibrillator on someone, I have to take off medication patches. And if I take that medication patch off, because I don't want the defibrillator around it, because a lot of them have a foil backing, it would arc. And so I need to get that patch off. The patch may be the problem, little Johnny and the fentanyl. I need to wipe that off, what's residual. I need to wipe that off with a gloved hand, with some, probably a piece of gauze or paper towel or something. I need to pull that glove off and turn it inside out to hold the material inside the glove and dispose of it as hazardous. Because if that gets on you, you're going to get it too. Now, despite media attention, do you guys remember not too long ago, there was a couple of police officers. The female police officer, as reported, was exposed to fentanyl. Found it in a traffic stop or something. She flipped out because she thought she was exposed to fentanyl. She was panicking. I was sitting with my wife and I saw that on TV come across, and it made national news for a long time because her officer partner went and got the Narcan and gave her the Narcan. And he was a hero. And fentanyl is bad. It's so bad, we carry fentanyl in the ambulance and we can't even tell our patients anymore, I'm going to give you some fentanyl for your pain. They're like, oh, I don't know, that'll kill me. Well, a police officer lady was flipping out on the ground, flopping like a beached fish. That's not a fentanyl overdose, is what I told my wife. She's like, how do you know? I've given it. You don't flop. You get really chill. And if I give you too much, as in an overdose setting, you're out. That's why you die from an overdose, because you're out. You don't breathe. You don't move. She needed a Xanny. She was having an anxiety reaction. And why not? Because all we've ever said was, hey, that drug dog sniffs of that fentanyl in that suitcase coming through that airport, that drug dog will die right there. Well, no. No. If he opens the bag and licks it, and guess what? He's trained to lick it. It's a treat. That's how we train these dogs to sniff this out. We make it goody for them. Why else would they work for it? Not your praise. We're question everything. You hear me? Over 50% of the material in medical textbooks has empirically been proven to be wrong. 50% of what is in that book that I have you read is wrong. What are the consequences? The researchers say it is incalculable. Question everything. Question everything. Remember, we were the people that thought if you breathe through a paper napkin, you wouldn't get sick. And if you walk the same way in the bread line, you won't get COVID. And there was a piece of tape on this floor, and you might be even still, and I had to stand beyond it because I was 6 foot from you. Question everything. That's proven. That's not me making that up. I didn't make that statistic up. 50%. Because by the time it goes to print, research has found that that's not true anymore. Okay? Giving epinephrine to someone in cardiac arrest may get their heart beating again, but it will kill the brain. We don't talk about the killing the brain part. We talk about getting the heartbeat back and taking them to the hospital and the paramedic going, we got to save tonight. We did good, didn't we? We really get those. We got us a save tonight. Is that the guy that went out by Bradshaw Funeral Home 4 hours later? Is that your definition of a save? Or is it the guy who went back to his house and called over his grandkids at a birthday party and bounced him on his knee? What's your definition of a save? It's a segue into our next chapter, by the way. Be careful. Now, fentanyl patches, nitro patches, estrogen patches, whether they're birth control or little old ladies went into menopause and she's wearing estrogen patches to keep her bone health up. A lot of you guys are like, I ain't touching that. Now, fentanyl, I don't know, but estrogen, I don't want any estrogen. Nicotine patches, there are a lot of patches out there. If it's on you and it's not yours, it's probably bad. There's the glucose gel, glucose tablets. Here's the deal with these oral medications of only if they are able to swallow and protect their own airway. Unconscious people don't get these. You hear me? I don't care if they're suffering from hypoglycemia, low blood sugar to the point they're passed out, nothing in the mouth. Don't be the guy who says, I'll put a little on my finger like old Hunter. Hunter's going to put a little syrup on his finger and rub it on their gums and go, this'll wake her up. I've seen EMTs and paramedics do it. Not paramedics. Hopefully that crap's out of their system by then. I saw a woman in church one day and her husband's having a seizure. He's unconscious. He's having a full-blown grand mal seizure and I'm with him. Him and I are walking the pews on the floor. We're going down to the altar. Here we go. It was during communion and people just kept taking their communion. I'm like, I want mine too, but I got to be with him. Here come his wife, opened up. I told him to take his pills today, and he didn't. And she was dropping pills in his wide open mouth. And I'm like, you can't do that. And I'm like, well, I guess you can, because you did. He needs these. We do not put anything in an unconscious patient's mouth, okay? Unless it's an oral airway. And they have to be able to tolerate it, right? You learned that last Thursday. This has to go into the gut. People say, I'll put some in my mouth and it helped me. You swallowed it. It did not absorb. The sugar molecule, the glucose molecule is too big. The fentanyl molecule is too big. To get fentanyl to go transdermal, it has to be mixed with other chemicals that will break the barrier down of your skin to even allow it to go in. These reports of I just brushed against it in the airport and I died.
So if they're unconscious and they're hypoglycemic, what would you do?
Call a paramedic because we need a needle. Y'all want to hear funny? Y'all love hearing funnies, right? It happens every year. We was in the cafeteria, senior day, 1,000 kids on campus from the high schools. Got one kid, bless his heart. He's one of those, maybe I should be careful. You could just tell I'm over there minding my business. Hey, Miranda. And I'm like, am I the only healthcare person on this campus? Mm-hmm. Okay. So I go over and I'm like, what's it? And he's on the floor and he's cold and clammy. And he's got a little tray of nasty nachos and a drink. I get over to him. I'm like, I could tell this kid's not nourished well at all. You know how I could tell? Look at his fingernails. his fingernails was a dead giveaway that this is a malnourished kid. We'll get into that in patient assessment later. I could also tell by his hair. He didn't have healthy hair. This kid's not well nourished. He's got poor skin color. Did you eat today? I know this is sugar. I don't need a glucometer. This is sugar. I've seen hypoglycemia and this is it. Would you like to take a bite of those nachos? And he's like, no. So let's go inside to where you're not a spectacle. Let's go sit at the table. He's outside against a pillar. He's got a coat on. It's summertime. We go inside. We sit him down at the table. I told Emily, she was with me. I said, Emily, go over there to Fountain Drink and get him a Dr. Pepper. Well, the school person, wasn't a school nurse, but the school associate, the school adult, said, his mom won't appreciate you giving him a soft drink. Okay. Then I'll wait till he passes out and I'll stick a needle in his arm and give him the Dr. Pepper. Because basically I'm giving him sugar. She comes back for the Dr. Pepper and I said, we're going to give him a Dr. Pepper, ma'am. Because he's going to go out if he doesn't get this in him. She said, I'm going to call the school nurse. You do so. You do so.
This is a college kid?
No, this is a high school kid on this campus. Can I treat him? Legally. In loco parentis, in place of the parent?
Dr. Pepper?
Or do I need that because it's life-threatening? It's life-threatening. I don't need it. What are the court's going to say? You let him die because a parent wasn't there? Are you kidding me? You're a trained professional and you knew what to do and you just sit there and let him die. Now, that wouldn't hold up in court, would it? I gave him a Dr. Pepper and it saved his life, but his mom didn't want me to. Now, which one sounds better in the courtroom? This kid takes a drink of this Dr. Pepper through the straw, and he goes, "Whoa!" And he looks at me all bright-eyed, and he's like, that's good. You've improved drastically in the last 2 seconds. Take another drink. And he's like, can I? And he's like, he is improving by the swallow. I mean, he's pinking up. His fuzziness is left. I said, will you eat that hot dog now? Yeah, if you put mustard on it. He's coherent. He's carrying on a conversation. Here comes the school associate. I talked to the school nurse. Oh, okay, I'm gone. Y'all deal with her. I'm out of here. I don't need to talk to her. Yeah, maybe I need to know if he's got a history or something, but they were more worried this kid had never had a soft drink, is the point. This kid had never had a soft drink. Now, I don't know about any of the other medical conditions he's had, and I don't know what his home life is, and that's really none of my business. My business at the moment was you called me over here to a kid who's hypoglycemic. He still has the ability to swallow at the moment. If he loses it, I don't have the ability to start an IV on him and give him sugar because I don't have that equipment with him. But I got the cure over here. The good doctor's over here in a soft drink machine, right? It could have been Coca-Cola too, but it can't be Diet Coke. It's got to be Coke, real Coke. It could have been orange juice. But what's the most available at the moment? Fountain drink, get it, drink it. And I knew he'd like it. Nobody dislikes it. They may tell you they dislike it, but they like it. It tastes a hell of a lot better than that to us too. So what I'm getting at here is also, you get on scene with these patients and they need this and you have this in your bag of tricks, and they just don't like the consistency of it because it's like this pasty, really thick jelly. I've seen orange flavored and they may not like orange, grape flavored and they may prefer cherry. Go to their kitchen. See what they got in there. If it's Dr. Pepper or Coke, use it. If it's honey, use it. You're just wanting some sugar in the body. and they have to be able to swallow. This is a mess. I'll be honest with you. The tablets aren't too bad, but this is a mess. But it's orange chewable. I mean, they're already nauseated. These people also, they get nauseated when their blood sugar gets low, and they really don't want to eat. And that's why this kid didn't want to eat those nachos. He had nachos in a bottle of water. That's gross in itself. This cheese-like substance they pour over the top of it. Ew. Now they're soggy, cold, and you want me to use water? Them damn Dr. Pepper. Some are inhaled as gases. Now, we only use oxygen. You may work for a place that the paramedic can use something called nitrous oxide. It's laughing gas that you see in the dentist office. We used to give that as paramedics for people with pain and anxiety. Take the laughing gas. We discontinued carrying that because it always leaked.
Oh no.
Some of you got it. Some of you are like, well, why don't you fix the leak? You have to check the equipment every day, right? You have to turn the bottle on and see how much pressure's in it, don't you? And then you got to bleed it off so it doesn't sit there under pressure. I mean, just because I was close. What's close? What's too close? Seriously, they quit carrying it for that reason. But it was awesome for our patients because we could give them the mask and they were having this pain or this chest pain and they could put the mask up and breathe on it. And it's like THC. They're not going to overdose because they're going to drop it. But how much did I give them? Self-administered, right? It was titrated to effect. So you don't see that much anymore. So let's look at the rights. The rights are important. Ding, ding. So make a note of the slide or the table 12.3 in your book. Table 12.3 in your book. Be familiar with this. These are called the rights of administration. Some people say 5 rights. Some people put 9 rights. I've seen 15 rights. Just kind of go through it for a minute. The right patient. So if you get to the house and someone's got COPD and they're having shortness of breath and you say, have you taken your inhaler? And they go, no, it's empty. But my wife has the same disease. Go get hers and use it. And so you go up to the wife's and you pick it up and it's made out to Martha and this is Bob you're dealing with. We still good here? Are you going to give it to her? Him?
No.
Same medicine. Same prescript. No, it's not his. Not his. With me? Right medication and indication. You're having trouble breathing, are you? Yeah. I heard fentanyl helps. Do you have any of that? If I've got a partner asking for fentanyl from a patient because they're having shortness of breath, they're drug seeking. I'd hate for you to believe that you would work with partners who would seek drugs from other people's homes. Be on the lookout for that. I don't want you to be private investigating. I just mean be on the lookout for that. You notice something odd, you need to report it. Chas, remind me to tell you a story. Tell everyone a story. No, right dose. Now, I like to use the echo effect here. It's called the echo effect. If a doctor or a healthcare professional who has the authority to tell you how much to give, you should echo that back verbatim. For example, your med control physician says give 0.25 Benadryl IV, and you report back, okay, that is 0.25 of Benadryl IV. And he goes, no, I said 25. Well, you said, or I heard 0.25. Are we confirming this is 25? Just clarify. You get my point? clarify. You're going to have medications in your ambulances at the paramedic level. You pick it up, and for one indication it's this dose, and for the next indication it's that dose. For example, I can give epinephrine 0.15, 0.3, 1 milligram per minute, 1 microgram per minute, 1 microgram per kilogram per minute. Which one of those applies? Well, it depends on the situation, doesn't it? But it's the same drug. You see how you could easily get messed up on that? Echo it back. If it's your partner, echo it back to them. If you're the EMT and the paramedic says, I need epinephrine 1 to 1,000. Sure, I'll get that out of the kit for you. I can't give it, but I can certainly hand it to you. I'm handing you epinephrine 1 to 1,000. He goes, no, I said 1 to 10,000. Confirming you want 1 to 10,000 epi? Yes, put that back in the box and pick up the 1 to 10,000. Epinephrine, but in 2 different forms. You with me? EpiPen adult, EpiPen pediatric. The dose is different. If you're giving little Johnny the EpiPen and him and his big sister are both allergic to bees, are you using hers or his? It's got to be the right dose. And that would go back to the right patient as well. But if mom runs out with an EpiPen and says, here's his, and you look down and go, that doesn't look like it would be for him. Right route. We already talked about how many ways you can give epinephrine. IV, IM, sub-Q. Would you repeat that back to the physician or the person giving you the instructions? Yes. Right time. Some medications we give every 3 minutes, every 5 minutes, just once, over a period of time. So we get that involved. The rest of them, if there were 5 that were important, it'd be the first 5. The rest of them are good. Right education. I'm going to give you epinephrine. It may make you nervous. I'm just telling you. I'm going to give you Benadryl. You may get drowsy. Just saying. Right to refuse. Oh, we don't ever think about that too much. I'm going to give you Benadryl in your IV. No, you're not. Why not? I'm allergic to it. Well, why are you allergic to it? It makes me sleepy. That's a side effect. I think you need the Benadryl to help you breathing. I don't want the Benadryl. I've already told you. Can they do that? If you give it and they say don't give it, that's a form of assault and battery, isn't it? Right response and evaluation. Any drug you give, including oxygen, if I give it, I need to reassess. Give it, reassess. Give it, reassess. What am I reassessing for? If it's working. Adverse reactions. Oh, crap. That happened. I knew that was a risk, but it happened. Now we got to deal with that. That happens sometimes. I gave him oxygen non-rebreather and he COPD. Now he quit breathing. Crap. That's an adverse reaction, isn't it? And I got to go do it. And then right documentation. This is probably where we make the biggest mistake. We'll say something like, for your example, Jonah, 15 liters per minute NRB, 15 liters a minute non-rebreather. And I document that. Did they know how much oxygen they were given? You could probably deduce how much oxygen they were taking. But I would be better suited by saying, gave oxygen FiO2 greater than 90%. You with me on that? That make sense to all of you? Here's another one. Gave an amp of D50. Paramedics give sugar in the vein, kind of like I talked about the kid in the cafeteria. If I had started an IV on him and pushed the sugar in the IV, it comes in a pre-filled syringe, and I'll show you those tomorrow. An amp is an ampule. It's not even, the nomenclature's even wrong, but people will say, I gave him an amp of D50. You ever heard that in the hospital? I gave him an amp of bicarb or something like that. You haven't told me how much you've given him. You don't even have the device correct.
Paramedics say that on the phone.
It's stupid. So fix it. Be a culture of change. You have to be. That's how they document it too, Jonah, and that's a mistake. Imagine that going to court. How much dextrose did you give the patient? I gave him an amp. And then they pull up the next slide. You gave him one of these. This is an ampule. You mean short for ampule? No. That's not what I gave. I gave this thing. Oh, a pre-filled syringe. Yeah, that. Well, that's not an amp. I hate to correct you here on the witness stand, but that's not an amp. Objection, Your Honor, he's insulting my witness. No, he's just stating the truth. How much sugar did you give him? I gave him 25 grams of dextrose as written on the bottle. 25 grams of dextrose. IV. That makes sense to you? Don't let our shortcut jargon be the way. Yes, you call a radio report, I know what you're talking about. Probably no issue there. But when I write it on my run ticket, I better have 25 grams of dextrose. Challenge you, if you can do this tactfully and not get the crap slapped out of you. How many grams of dextrose did you give him? You can be sneaky and sly. How many grams of dextrose did you give him? An amp. A lot of times they don't even know how much. 25 grams, which is 100 calories. I don't know. So tomorrow we're going to play with these drugs a little bit. Got the oral medications, oral glucose. We've already talked about this. Let me point out, instead of just flipping through the slides, let me point out the drugs that typically the EMT pulls out of their bag of tricks. Oral glucose is one of them. An EMT will carry a med bag, so to speak. An EMT has oral glucose at their disposal that says, this is the right patient, right time to give this. And they can do it. It's sugar. Not without risk, but the risks are very... You're not going to kill the patient if you give them sugar and they did not need sugar, okay? You're giving them about the equivalent of a bite-sized Snicker. Even if you give them an amp of D50, it's the equivalent of a bite-sized Snicker. And the only reason you're giving this oral glucose is to wake them up enough to go eat something substantial. And it is not uncommon anymore, and I think it's good patient advocacy. That means fight for the patient, right? If I wake you up out of your recliner, when I say wake you up, you're weak because your sugar's low. I give you some oral glucose. You're with it now. I look in the kitchen and there's stuff to make a sandwich out of. Hey, that's not going to last very long because there's not a lot of calories in it. Do you mind if I make you a sandwich and sit here and watch you eat it? You think that's okay? Or you're going to swoop them up, put them on the cot, lights and siren, let's haul ass to the hospital and get a $1,400 lunch. Because that's all they're going to get at the hospital. They'll get a little bit more so they can bill more, but they'll tell you, go follow up with your endocrinologist and you should really take better care of your blood sugar. You need to keep an eye on that because this could be life-threatening if the paramedics hadn't gotten there and treated you. Hey, you're looking a little bit better now. So I understand you took your insulin this morning, but you got sidetracked because of a phone call and you didn't eat your meal when you were supposed to, and that's how you got in this position. I'm here to help you eat that meal. I've given you the glucose, and now you can talk to me a little bit better, okay? Do you want to go ahead and have that lunch now? That's advocacy. Call back to your station and say, we're going to be on scene a little bit. We may be whatever, how that works out. You see what I'm getting at, right? What's definitive care for that patient? Calories. Is it available? Yes. I promise you the ER will love you. Now, someone who you can't explain how they got in that hypoglycemic state, don't have the resources, look too incoherent to follow through, doesn't have a family member to sit in the house with them, okay, they need to go. Use common sense. Do not give to anyone who can't protect the airway. Another drug that you may have in your bag of tricks, and that's going to depend on local protocol, is aspirin. If I stress anything to you right now, we're going to give aspirin to people who are suffering from chest pain that we suspect they're having a myocardial infarction, which is a fancy word for a heart attack. Another way of stating it, we give aspirin for cardiac-induced chest pain. But you are not giving them the aspirin to get rid of the pain. Don't be ignorant. I test every EMT student over the years, and when they say in a scenario, I'm going to give the patient an aspirin, I'll probably give them 2 to chew and 2 to swallow for a total of 325 milligrams. I'm like, great, awesome. Why are you giving the aspirin? To get rid of the pain? This is not getting rid of a headache with aspirin. We are giving the aspirin for this. And I want you to say from now on, when someone says, why did you give aspirin to the chest pain patient? You say, I was inhibiting platelet aggregation. Okay, you know what you're talking about. If you say, because they were having pain and aspirin's a pain reliever. Wrong indication, right, Luke? Wrong indication. Aspirin, acetylsalicylic acid, aspirin is abbreviated ASA. Put that on the board. You need to know that. The medical abbreviation for aspirin is ASA. Some of you are like, I'd just rather take the test and go home than deal with this all for 3 hours. ASA. It originally came from the bark of a willow tree. So the native people or people who use plants for medicine, which a lot of our medicine come from plants, the bark, the inner bark of a willow tree, they would peel some, throw it in their mouth, get rid of a toothache, get rid of a headache. We give them baby aspirin, so it's chewable. And that baby aspirin is 81 milligrams per tablet. Most protocols say give 160 to 325 milligrams. I don't know why they say 325, because if you do the 4 times the other, you don't get 324, but whatever.
How much did you say
Close
about
enough.
baby aspirin?
1 to 4. 1 to 4. A lot of protocols, 2 to chew, 2 to swallow. Yes.
So, just like hypothetical,
Uh-huh.
more of an ethics question. But,
Sure.
if you have someone that is allergic to aspirin,
They don't get it. Yeah. Damn the luck. Because you have to ask before you give it, are you allergic to aspirin? Now, a lot of people are, and you'll find aspirin's like most things they are allergic to. It contains a protein. Where'd the protein come from? It's a plant protein, a salicylic acid that came from the bark of a willow tree, or synthetically identical.
What if they don't know if they're allergic?
We're going to find out, aren't we? We're going to find out.
Are there any other platelet inhibitors?
Oh, yeah. Plavix.
Why not? Like I'm saying on the box.
Well, McKinney Fire, I know for a time, was carrying Plavix instead of aspirin. And Plavix, basically, mechanism of action is the same, but it's higher powered.
So nitro is for the pain.
Nitro is a vasodilator. There's none of these for the pain other than morphine.
When do you choose to give nitro versus aspirin?
I'll probably give both, as long as the blood pressure will tolerate it. We'll talk about that in a minute. What? They have 2 different actions. I don't want you to form a clot. We'll do cardiac next week. I don't want you to form a clot, hence that's the aspirin. I want your coronary arteries to be as open as they can and still have a pressure. That's the nitroglycerin. If your oxygen is below 90, I want to bring it up. And I know I did not say 94, I said 90 for purpose. Your protocol will probably say 90. Textbook says 94. I hate to cause the confusion, but I didn't do it. I'll give you the oxygen to bring up the hypoxia if it's present. And if you're a paramedic, you'll probably give morphine or fentanyl, which is a higher powered morphine. And that's to relieve that pain, Jonah, and anxiety. So we're hitting it with, Billy, 1 punch, 2 punch, 3 punch, 4 punch, to buy time till we get to the big punch, and that's the cath lab.
So you can use nitro and aspirin?
Sure. Well, I feel like you were taught otherwise.
It might have been a different medicine other than that's not aspirin. That
Okay.
you don't use it.
With nitro?
Yeah, since it's a vasodilator, and then use something else, it's just gonna tank the blood pressure. I might do it.
You're talking about the good old Viagra.
Probably.
Yeah, if a patient is taking ED medications, erectile dysfunction, Cialis, Levitra, Viagra, nitroglycerin, we'll pause at this slide, and you guys will remind me next week where we picked up. But it's a great pharmacology thing. Viagra was originally made for chest pain patients. When it went to clinical trials to be tried out in patients, they got 1,000 people who suffered from cardiac disease. Hey, come in. We're going to try this medication on you. It's going to lower your blood pressure if you have high blood pressure, and it's going to, or we think it's going to, ease your chest pain when you have episodes of angina because you have cardiac disease. So they got these people to volunteer for this study, and they gave them this new drug, and then they gave another group a placebo. Y'all know what a placebo is? It's just a sugar pill. It's inert. It doesn't do anything. And that's called a blind study. So you don't know if you're getting the real pill, the trial pill, or the sugar pill. Now, the researchers know who's getting it, but you don't know if you're getting it. It's a blinded study. So you take this, and then you go back and you report to the researchers the findings, and they ask you questions. Did you take it when you had chest pain? Yes. Did you take it to lower your blood pressure? Yes. Did it help your chest pain? No. Did it have an effect on your blood pressure? Not much. Did you notice any side effects?
Yes.
You got any more of it? And they're like, the researchers, this is a true story. The researchers looked up and said, they went back and compiled the data, and they're like, what did your group have? What did your group have? Here's the most common side effect: erections. Erections in men who don't have erections, who are impotent, who suffer from ED. What do you think the people who designed the drug said all of a sudden?
Hell yeah.
We're going to shift gears.
That's money right there.
We're going to shift gears. So they pulled it from that indication, reapplied to the FDA for this indication, and it won approval. Now, since that drug is a PDE5 inhibitor, it allows those muscles to relax, those vessels, those smooth muscles to relax. So you have that on board, and then you give a nitroglycerin. Now you've 2 + 2 is 5. You've got more effect than you would have had by either one of them alone. The sum is greater than the individual parts. So you're supposed to ask people, have you had an ED med within the last 24 hours before I give you the nitroglycerin? Well, Cialis changed all of that because it's once daily. So if the patient elects to take Cialis, they take it daily. Does that keep you from taking nitroglycerin? The answer is honestly no. You're just going to have to be really cautious with the blood pressure. And to the EMT, it probably is no, because the dose we give of nitroglycerin at the EMT under the tongue is a massive dose. For example, if you're in the hospital and they give it to the IV, it's like 10 mics, 10 micrograms 5 micrograms per minute. You're giving 400 micrograms at once under the tongue. Now, granted, IV versus tongue, but it's still a big dose. If I give them that tablet or spray under the tongue, can I titrate?
No.
If I give it through the IV and I've got a clamp that will adjust the speed of the medication, can I titrate?
Yes.
Yes. So in that setting, with the IV, I can start low and up it until I get the desired effect, or the blood pressure starts becoming an issue. I've talked to cardiologists, I've talked to people who work in cardiology clinics, I've talked about, hey, we got this issue. We can't give nitro because they got an ED drug on board. And they're like, we just treat it like everybody's taking an ED drug, because they're gonna lie to you. They're probably gonna lie to you anyway. It's a little more societally accepted, especially the average age of erectile dysfunction is coming down every year. And so if trends continue, you guys in your 20s will start suffering from it. So there's more of that being prescribed. And so it's a little bit societally more accepted. But I tell you, back in the 90s, when Viagra first hit, it was kind of like taboo. You're like, don't admit you're taking that. I remember going to people in the family's 50th birthday party, and there would be a sample pack of Viagra that would just pass through the family. Everybody turned 50 got the pack, and you're like, I turned 50, nobody gave me a pack. It's just like, that joke's over. That's a dead joke now. So you have to be aware of it. But you also have to be aware if they're taking fentanyl or morphine, because it's also a smooth muscle relaxant, and which in turn is a vasodilator. Anytime you give anything that's going to lower the blood pressure, you have to be cautious of it. Absolutes, maybe at the EMT level, it's an absolute. I'd call med control. But if their blood pressure was 160 over 110, they probably need the nitroglycerin. If their blood pressure is hovering, the cutoff's 100 systolic. If their blood pressure is lower than 100, some medical directors will say, you're cool at 100, you can go all the way to 90 before you have to worry. Anytime I give nitroglycerin, I'm going to worry. I don't care what their pressure is. I know it could bottom out. Some people are super sensitive to it. We'll talk more about that in cardiology next week. I had a story, but I've only got 10 minutes. I don't remember what the hell it was now. Oh, it was about a battalion chief who was, not technically he wasn't a battalion chief, he was chief of EMS operations in McKinney Fire Department. And this is made public, so I'm not hiding anything here or telling anything I shouldn't. He was chief of EMS operations. So like there was the fire chief, there was the fire operations guy, and there was the EMS operations guy. That's the chain of command. He was in charge of all the ambulance stuff. And he got pulled into an interrogative interview by U.S. Marshals, the FDA, the EPA, Texas Rangers, McKinney, Collin County Sheriffs, McKinney PD, Fire Department Internal Investigation, all this stuff. There was a guy sitting there, this 2-year firefighter, paramedic guy, and all these people were interrogating him and going, you're stealing Valium benzos from the station. He's like, no, I'm not. Like, we know you are. You need to admit it. And this kid sitting there going, I am not doing this. They worked on him so hard that he almost admitted to it. But he just broke down. I mean, they're threatening him with pulling his license, his career. Think about your family. Think about your job. You go ahead and admit to this. We'll get you help. You get to keep your license. Maybe you can come back to work for us, blah, 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 blah. I don't know how it was all set up. I don't know what was going on behind the scenes, but the EMS chief over here said, stop, just stop. And he just broke down. He said, it's me. You're not hooking that onto him. He didn't do it. It's me. Now, I think the interrogators knew it was him. They were just going to get at him by going to this guy. Does that make sense to you? That's how I think they did it. Nonetheless, he admitted to it. What had happened was, on a routine seizure call of a pediatric patient, the paramedic gave Valium. Didn't stop the seizure. Repeated the dose. Didn't stop the seizure. Called med control. Med control said, try Ativan. Got some, didn't stop the seizure. Hey, we're en route. We cannot stop this seizure. They get to the ER. The doctor said, so you've given like 3 Valiums and 2 Ativans and we're still going? Yes, sir. He looks at the nurse and he says, go ahead and give him another Ativan. Let's see what happens. And we'll go from there. She gave him the Ativan. He stopped seizing. So they got to talking like, how did you stop it? And the doctor said, go out to your ambulance and bring in your benzos. So they went to the ambulance, they brought in the benzos, and they're on them little vials, and you'll see tomorrow they got plastic tops on them. And those tops should spin. These tops wouldn't spin. They were glued back down on the deal. So long story short, this guy, well, actually they checked the other ambulances, tampered. Checked the supply room, tampered. Checked the expired ones that were supposed to be disposed of, tampered. There were no benzos in McKinney Fire Department. They had all been tampered with and replaced with sterile water. Immediately, ground halt, stop all benzo administration until we get to the bottom of this. And after weeks and weeks, they finally find this out. Well, in the meantime, they had to go back, I don't know how many years, but it was more than one. Probably statutes and limitations, if I'm guessing. They went back those years, as far back as they could go. And every patient who had been given a benzo got a letter from the city of McKinney saying, if you or someone you know has been harmed or killed, call us. You're probably entitled to compensation. Luckily, nobody had suffered ill effects from this. That kid could have. A kid could have died because the medications used to stop his seizure didn't stop it. If it went to the ER, he would have. There was no benzos in the department. He had tampered with every one of them. Fired immediately. I don't know if he served jail time or not. Probably plead out to rehab or something like that. Lost his license, lost his job, lost his career. I do know that much. Because a good friend of mine took his position and had to clean all that up. And it involved the FDA, the EPA, the DEA. I've been involved where the DEA has walked into the fire station before and said, I need your drug kit. And it's a guy in a suit and tie, and the next guy looks like he just came off the streets from a gang. And his name was, they called him Snake. He was the enforcer. They were both FDA agents or EPA, DEA agents. And we had messed up. Our medical director had messed up and prescribed a medication. Our medical director was actually in handcuffs in the car out front. Like, oh, we just lost a medical director. And they're like, yeah, you did. You're going to go basic only. You're pulling your advanced life support until this is cleaned up. The storage of drugs, the keeping of drugs, it's a really, really big deal out there. And we'll talk more about that. Your EMTs never handle the narcs. Never handle the narcs. There's a chain of custody with those, and if you handled them, you're in that chain. And you could easily be falsely blamed for something going wrong. Okay? Tomorrow's lab day, so dress like you know how to dress. No shorts. And we'll do med administration.